Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everybody. Tonight we would like to introduce the second tetrad organized by Sanofi. In the previous one, the first one, we discussed the atopic dermatitis in pediatric age group. Tonight we will discuss adult atopic dermatitis. This topic about the chronic multifaceted condition, which is burdensome for clinical as well as economical perspectives. Tonight we will highlight on this burden of this disease as well as different real-world management data from around the globe. I'm glad actually to introduce my colleagues, Dr. Ayman Al-Harbi. He is a consultant dermatologist and head disorders. He's in King Abdulaziz Hospital in Mecca, and he's chairman of local committee of dermatology training in the Western region. Then we have Professor Ayman Al-Jindi. He's a professor of dermatology. He's a consultant dermatology and head of the dermatology department in Saudi Medical Services. We have also Dr. Ahmed Ismail. He's a consultant dermatologist and head of dermatology department in Irfan and Bagido Hospital in Jeddah. Actually, tonight we have 4 topics. The first one is the prevalence of atopic dermatitis. The second one, burden and comorbidities of atopic dermatitis. Third one, the real-world evidence for systemic therapies in atopic dermatitis. And lastly, meta-analysis and systemic reviews. We will start with the first topic. I will ask Dr. Ayman Al-Harbi. Can you please, Dr. Ayman, tell us about the prevalence of atopic dermatitis in adults?
Yes, of course. Actually, the prevalence of atopic dermatitis is very high, mostly in the first years of life, which is approximately around 80%. Recent studies indicate the evidence of adult-onset atopic dermatitis, but the incidence across different age group and countries remain still unclear. Knowledge of the prevalence and the incidence of atopic dermatitis in different age group is very important because it's essential for healthcare planning and also for patient counseling. So there is different studies like a systemic review studies, which shows the prevalence and the incidence of atopic dermatitis. The primary objective of these studies to review and analyze epidemiological studies in the prevalence and the incidence of atopic dermatitis during the childhood and adulthood, focusing on the data in the 21st century. So the result of these studies was in the adult, the overall prevalence is ranged from 1.2 to 9.7. On the first years, atopic dermatitis symptoms is varied from 1.3 in Germany to 22.7 in Kuwait. And the lifetime prevalence of atopic dermatitis range from 1.7 to 17.7 in Kuwait. The prevalence of atopic dermatitis in Scandinavia is in the age group between 0 to 29 years is around 34.1%, which is very high. So I think as assessed by both patient and physician, atopic dermatitis is a common disorder that has increased in most countries. The second studies, there is studies about epidemiology of atopic dermatitis result from international survey. The objective of these studies is to estimate the prevalence of atopic dermatitis and the disease severity. Its international studies based on the survey was performed in United States, Canada, France, Germany, Italy, Spain, and United Kingdom, and also Japan. And the result of the studies was 4.9 of atopic dermatitis percentage in the United States and 3.5 in Canada, 4.4 in Europe, which will increase also in Germany, in some countries like Germany to 8.1, and in Japan it's 2.1. And also we found that it differs from the sex and the age. They found that the prevalence of atopic dermatitis is more common in the female than in male, except in the United States in this study. And also they found that the atopic dermatitis increase incidence during the early age. It's more increased between 25 to 34 years, which decrease in the older age from 45 to 54 and also from 64 to more. And also the severity is different from one country to another regarding to this study and to the scaling score. So in summary, the atopic dermatitis prevalence is very common, and it's a range from 2.1 to 4.9 across the countries.
Thank you, Dr. Ayman, for these valuable informations. My second question will be for Professor Ayman Al-Jindi. Professor Ayman, about the prevalence of atopic dermatitis, going in line with your practice, what you see in your practice in the clinic?
Somewhat incidence of the atopic dermatitis in my patients consistent with these results, between 15 to 25% in pediatric patient and between 3 to 5% in adult patient. That's why somewhat consistent with the prevalence of atopic dermatitis, which mentioned by my colleague Dr. Ayman Al-Harbi.
Okay. What you mean that in adult atopic dermatitis is much less than pediatric?
Sure. Adult in all ages.
Do you mean that the start of the atopy, or both of them, either they have it since childhood and continue with that, or the cases which are started late onset?
I am not talking about adult onset or late onset or very late
all
onset.
Together.
But in general,
the
incidence of all patients with atopic dermatitis during adult phase, including early onset and continue to late onset, 3 to 5%.
Okay, thank you. My next question, again for Dr. Ayman Al-Harbi. Do you think that it's important that to have a national registry for atopic dermatitis in Saudi Arabia?
Yes, it's very important, of course, because we need actually more center and also more data collection for atopic dermatitis prevalence, and that will be help us actually for treatment strategy and to compare the effectiveness of the treatment and to prevent the comorbidity of the disease of atopic dermatitis. So I think we need in the future national registry for atopic dermatitis in Saudi Arabia to for preventive and also for therapeutic approach of atopic dermatitis.
But I wanted to add one point, please. I think there are registries for instance of atopic dermatitis in Saudi Arabia. There are, but somewhat old. But some registries from, I think, South area, some registries from Al-Khobar, but this is all the registries. That's why we are need for recent or updated registries. But they were.
Yeah, good. Thank you, Dr. Ayman. And now we will move to the second topic, which is the burden of and comorbidities of atopic dermatitis. My next question will be for Ahmed Ismail, Dr. Ahmed Ismail. What are the most common comorbidities in atopic dermatitis, and what is their impact?
As of all know, that atopic dermatitis composed of heterogeneous disorders with variable skin morphology, starting either from simple erythema and scaling up to intense itching with production of what's called prurigo nodularis. There is a lot of recent global systemic review and meta-analysis of the characteristic identified, there is about 78 different signs of atopic dermatitis, different signs and symptoms of atopic dermatitis. All these factors will contribute to a lot of psychological and social and even physical comorbidities. If you are trying to classify these comorbidities, we have two types of comorbidities. First one is the atopic comorbidities, including the asthma, including the food allergy, and other the non-atopic comorbidities, including the allergic conduct dermatitis, including anxiety, including depression, suicidal tendency, ideations, infections, and even the cardiovascular disease. Regarding the atopic comorbidities, the lifetime prevalence of bronchial asthma and 1 year prevalence of food allergy were increased in adults with more severe atopic dermatitis. The prevalence of asthma increased with more severe scores, especially if we are talking about the SCORAD index or the patient-oriented eczema measures as reported globally. The severity, we can find that 63% up to 73% of adults with severe atopic dermatitis reported to have a bronchial asthma during their lifetime. Also, the increased prevalence of the food allergy, we can reach up to 17.4 or up to 42.9% of adults with severe bronchial asthma, with severe atopic dermatitis can develop food allergy. Regarding the other comorbidities, we have also the cardiovascular comorbidities, but the cardiovascular comorbidities not related directly to the pathogenesis of atopic asthma, but it can be related indirectly to the atopic dermatitis. Maybe because of the increasing the risk of chronic sleep disturbance, sedentary lifestyle, also increasing the prevalence of smoking, in addition to the common side effect of the medication used in treatment of bronchial asthma, like systemic steroid, which can give the patient hypertension or metabolic comorbidities, in addition, for example, to the cyclosporin, which can induce hypertension or even renal impairment in patients with atopic dermatitis.
Thank you, Dr. Ahmed. But one other additional thing, maybe I would like to clarify about the pollution which we are living in modern life.
Yes, this also can add a burden to the disease, the comorbidities of the atopic dermatitis. The pollution can give us more pathogenesis. Also, the staph colonization can give us more severity of the atopic dermatitis clinical symptoms and signs.
Okay, thank you, Dr. Ahmed. My next question will be for Professor Ayman Al-Jindi. What other comorbidities associated with atopic dermatitis you can see?
From my clinic, I think the most important comorbidities, number one, infections, particularly bacterial and viral infections, viral herpes simplex, and even molluscum contagiosum is common among patients. Psychological comorbidities, of course, is common, anxiety, depression, ADHD, obesity. It is very common comorbidities, particularly in patients with moderate with severe atopic dermatitis. Other manifestation, of course, as Dr. Ahmed Ismail said, of atopic march like bronchial asthma, rhinitis, food allergy. Also, we have some rare comorbidities, rare, very, like vitiligo. It is common. I reported cases of vitiligo among my patients with atopic dermatitis. Alopecia areata, it is also uncommon comorbidities with rare comorbidities, but very important. T-cell lymphoma. I reported about 2 cases of T-cell lymphoma among my patients of atopic dermatitis. But regarding cardiovascular comorbidities, I don't have any cases of cardiovascular comorbidities among my patients. That's why I am not sure that this is a real comorbidities, cardiovascular, and I want to see any comparison between cardiovascular comorbidities among patients with atopic dermatitis versus among the normal populations, because up till now, I don't agree with the studies that mentioned that cardiovascular comorbidities is important for patients of bronchial asthma. Maybe very common among patients of psoriasis, sure, but regarding atopic dermatitis, I am not sure.
You did not observe any
No,
increase?
no, I didn't.
Even if we consider that as a chronic inflammatory condition, and by this indirect way we can
No,
add...
indirect way, even indirect way. In atopic dermatitis, no, because IL-4, IL-13, not associated with atherosclerosis or cardiovascular. But in psoriasis, for sure, IL-17, TNF-alpha, IL-23, associated with increased risk of atherosclerosis and cardiovascular comorbidities.
Thank you, Professor Ayman. My next question will be for Dr. Ayman Al-Harbi. Dr. Ayman, as all we know that atopic dermatitis carries economic burden. Can you tell us about this burden for atopic dermatitis patients?
Yes, actually, atopic dermatitis increase the burdens either directly, as Dr. Ayman mentioned, or indirectly. And there are a lot of studies, like some studies was mentioned in Europe about the economic and psychological comorbidity burdens among adults with moderate to severe atopic dermatitis. The aim of these studies is measuring the economic burden, direct and indirect cost in the moderate to severe atopic dermatitis. And the result was over 1,014 patients was the direct cost between 2,000 to 7,000, and also the indirect cost burden in Europe, it's from 7,000 to 14,000, depend on the severity of atopic dermatitis. So overall, the result of these studies was the burdens of atopic dermatitis is very high, so we need preventive measures, and also we need an effective treatment to prevent this cause of the burdens of atopic dermatitis.
Please, I have one comment I have to ask the doctor. Do you think that during the era of biologic like dupilumab and JAK inhibitor, this era, do you think that increase economic burden or improve economic burden? What's your opinion? The very expensive medications, as a dupilumab, as a JAK inhibitor, do you think that these medications will increase the economic burden or improve the burden through improvement of quality of the life of the patient and increasing productivity? What do you think?
It's actually decrease the burden, because the effective treatment is prevent the comorbidity, so it's prevent the indirect cost of and the complications of atopic dermatitis, so it's decrease the burden.
True. After all, the whole picture will be improved. After, okay, maybe the medications, the biologics are expensive medications, but after all, after we control the comorbidities and the chronicity of the disease, improving the life of the patients, of course, all will reflect the improvement and decrease the burden of the economic situation. Okay, thank you, Professor Ayman, Dr. Ayman. And my next question for Dr. Ayman Al-Harbi, I need actually your suggestion to address atopic dermatitis burden in Saudi Arabia.
We need first to educate people about atopic dermatitis and criteria of atopic dermatitis, to early diagnose, and also to prevent the aggravating factor. Second, we need research centers to more registry about the prevention, and also about the effective treatment for atopic dermatitis to treat the atopic dermatitis and to prevent the indirect cost burdens of those patients, and to prevent the complications related to the atopic dermatitis. So this is what we need to decrease the burdens of atopic dermatitis in general.
Thank you. Do you think concentrating on the media, actually, especially the social media nowadays, is going on and is increasing its importance? Do you think if we concentrate on that, will reflect or will add more also?
Yes, of course. Education of the people, it's very important.
Through the social media, I mean.
Through the social media, through Twitter, Facebook, through any social media, it will be help. So even the Snap nowadays, it's help a lot of people about how to prevent atopic dermatitis complications and how to treat. And also we need actually to regular visit of atopic dermatitis patients to the doctors. And we need our primary health physician to help us to treat the patient of atopic dermatitis and also to refer patients with moderate to severe atopic dermatitis to the dermatologist directly and urgently to prevent the complication.
My next question will be for Dr. Ahmed Ismail. Actually, how impact is real-world evidence on clinical practice and why, Dr. Ahmed?
Now we have a lot of data available for dupilumab treatment in a daily practice setting now are available. But we have to differentiate between two types of the study. First one is the randomized controlled studies and the real evidence studies. The one for the randomized controlled trials are often carefully screened based on inclusion and exclusion criteria. And in contrast, in the real evidence world, there is unselected and therefore probably less compliant, and mostly you have some patient will have another comorbidities. So it is very important to take both of them. Now we are going to discuss some of the atopic dermatitis registry worldwide. We have a lot of registries worldwide up to now. Some of these registries, the results are available, and others the result is not available yet. We have the BRUISE 1, we have the ADREN 02, we have the Eurostat, we have the BioDay, we have the ATRG. We have a lot of atopic dermatitis registries worldwide. I am going now to discuss two of them. First one is the ADREN 02 one. This registry, the purpose of this is a multi-center clinical registry study is to determine the genetic markers and susceptibility of infection in patients with atopic dermatitis. By the way, it is a 7-year observation study with actual enrollment of about 3,300 plus patients. And now we are waiting for this publication for the result of this ADREN registry study. If you are going to discuss another one with some release study, you are going to discuss the BRUISE 1 for atopic dermatitis. It's a multi-center longitudinal prospective up to 5 years observational registry. Objective of this study to report the real-world early trends in improvement of atopic dermatitis through objective assessment of patient on dupilumab. Start with a patient with moderate to severe atopic dermatitis treated with the dupilumab. This data till now we have 315 patients with enrolled and 187 patients completed up to 6 months of the treatment with dupilumab. If you are going to show the result of this study, we can use a lot of measurement to assess the result of this study. First one is the EASI score. Second one is the DLQI. We can use also the NARS score for brightest. We can use a lot of will be available now with a lot of results. If you are going to see the mean improvement in the EASI score, we can see there is an improvement within starting, it can appear from the 3rd month up to 6 months. There is an improvement in the mean EASI score. Also, there is an improvement in the mean brightest NARS score. There is an improvement in the DLQI score. In addition to another measurement like the body surface area affected, we can see there is an improvement by the 6 months of the treatment. In addition to the patient-oriented eczema measurement, also we can see there is improvement regarding using this score. By this, we can conclude that this real-world study demonstrates an improvement in patients with atopic dermatitis in adults over the initial 6 months of dupilumab treatment using different measurement tools like IGA, like the EASI score, or even the DLQI index score.
Okay, fine. Can I know personally which one do you prefer? You mentioned many scores for the atopic dermatitis, but personally for your, which one do you prefer to use? And is there anybody with you in the clinic to help you for achieving these scores?
Yes, for me, I am depending mainly on the physician global assessment score, which is easier for me, non-time consuming, in addition to the impact on the patient quality of life. I'm using the score, I'm giving the patient the sheet to take the questions and then give me the answer to collect the data. In sometimes because I'm working in a private sector, in sometimes before asking for approval for starting this treatment for some patient, the insurance company will ask me about EASY score. So in some times I have to use the EASY score measurement, especially if I am submitting for approval for insurance company to start the dupilumab injection.
Yeah, thank you. Actually, I asked about this because all of us are suffering from the limitation of time and the crowdness in the clinic. So just I want to share with you this problem. My next question for Professor Ayman Al-Guindi. Professor Ayman, what are other registries has been implemented in other parts of the world?
We have, sure, other registries like Eurostat registry. This is interesting registry, 5-year registry, include about 300.8 patients collected from 10 European countries. By the way, Eurostat is abbreviation of European Prospective Observational Study in patients eligible for systemic immunosuppressive treatment in atopic dermatitis. This study describes the characteristics of patients with atopic dermatitis treated with systemic immunosuppressive treatment and their management in a real-world setting. But up till now, the data and results of this study is not available. This is very interesting figure for me. Why? What this figure means? This figure showed that regarding the treatment included, systemic treatment included in management of atopic dermatitis. As we see in 10 European countries, 40.5% of the patients treated with cyclosporine, 23.3% treated with methotrexate, 19% with systemic steroid, about 18 or 18.3 treated with dupilumab, 5.6 with azathioprine, 2.8 with mycophenolate mofetil, 1% tofacitinib, and 1% hydroxychloroquine. This figure showed that up till now, or in this study in 10 European countries, the most common systemic treatment for atopic dermatitis is still cyclosporine, 40%, while only 18% of the patients treated with dupilumab. That's why this is a very important question for me. Is it due to financial problems, the high cost price of dupilumab? Maybe. Is it due to unavailability of dupilumab in some countries? I don't think so. Lack of awareness of many dermatologists? Maybe. That's why I wanted to ask Dr. Ahmed and Dr. Ayman, what's about your opinion? Why is still cyclosporine, which is broad immunosuppressive treatment, require better treatment monitoring with more adverse event, why is still the most common systemic treatment? What's your opinion?
For me, I think the cost, the cost burden, the financial burden is a barrier for starting this, yes.
Dr. Ayman?
Agree also, and also the effectiveness sometimes it's rapid of the cyclosporine, more rapid, but the side effect actually is more serious.
Yes, let me share with you something which I do in my clinic, in my practice actually, regarding cyclosporine. As Dr. Ayman mentioned, the fast action and also the delay in the achievement of Dupixent. Most of the time we cannot reach these medications quickly, either in governmental hospitals or in private hospitals. So the easy and the approachable tool which we have is cyclosporine. We have easy medications and fast action. This is, I think, this is why it is still till now achieving this percentage.
This is the case of your patient also? The most common systemic treatment?
As a beginning, and we can start as a beginning for sometimes first line if it is severe, of course. But I mean, if it is in our condition, while the dupilumab is not available as a quick medication we can start with, and other things, sometimes we have some we have to fight for a while with the insurance company.
Fight.
Yeah, I mean it. Yeah,
Yes.
with the
Yes,
insurance
yes, yes.
company, yes. Yes, because they are many times they are rejecting, many times they are trying to delay the medications because of course, because of the
So many factors.
the expenses of the medications. Yeah, Katas. Yes, of course, we are fighting with some insurance company to achieve this medication because of its expenses. As a solution, as a fast solution, I think cyclosporine will be the one because will give us fast action, and it is already available in the pharmacy. This is what I meant by it.
It's rapid, effective, and also sometimes the safety of the cyclosporine in pregnant lady. It's helpful if there is an aggravating atopic dermatitis or severe atopic dermatitis. So we give the patient cyclosporine, then as first management, and after that we tapering until we stop because the side effect of the cyclosporine.
Dr. Ahmed, what is the most common systemic treatment used for patients with moderate to severe atopic
By the early launch of Dupixent, I think, yes, cyclosporine was the first choice, because in some insurance company was insisting to start on a conventional systemic treatment first before going to the biological treatment. But now, after I think few years, now we have a choice to start either the biological treatment, Dupixent, or even to give the cyclosporine.
Okay, thank you. My next question again for Professor Ayman. What were the treatment pattern in Treat Germany and its main outcomes? Can you?
Treat Germany, this is big registry, include about 612 patients treated with systemic treatments, including dupilumab, about 173% treated with dupilumab. The patient collected from 32 centers, which means very big registry. This registry measure or evaluate the real-world effectiveness of systemic treatment of atopic dermatitis and their adverse events. Regarding the cyclosporine, as I said before, 173% of those patients, treated with dupilumab. 25% of the patients were bio-naive. Almost 1/3 of the patients had previous treatment with cyclosporine. 1/3 of the patient has a previous treatment with systemic steroid, which means bio-experienced patient. Regarding the effectiveness, not efficacy, because I wanted to clarify a very important point. There is a difference between effectiveness and efficacy. Effectiveness means performance under real-world condition, but efficacy means performance under restricted condition, under controlled condition. That's why this study demonstrates effectiveness, real-world effectiveness, and the adverse events of different systemic treatment, but in particular, dupilumab in patients with moderate to severe atopic dermatitis. When we are going to the results of dupilumab in this registry, as we see, about at week 24, about 52% of the patients achieve EASI-75, and 31 patients achieve EASI-90. This is very high results. And I wanted to clarify some point. The highest efficacy of dupilumab achieved between week 24 and week 28, not at week 16. All this slide showed that dupilumab induced about 70% improvement of mean EASI score, which is very high efficacy. Regarding SCORAD, as we see, dupilumab induced about 60% improvement of SCORAD score at week 24. Regarding symptoms, as we know, itch is the most important symptom, and this is the most important burden of atopic dermatitis. As we see, dupilumab induces more than 60% improvement of NASO score of itching. What is about the sleep? As we know, about more than 80% of the patients of atopic dermatitis, they have sleep disturbances. This figure showed that dupilumab induced more than 70% improvement of sleep score, which means improve sleep disturbances. What is about DLQI? Dupilumab, this figure showed that induce about 70% improvement of mean DLQI, which means that dupilumab improve quality of the life of the patient, change the quality of the life of the patient. And this is the real value of biologics, either in atopic dermatitis or in psoriasis. Also, as we see, dupilumab induced 70% improvement of mean PWIM score, or patient-oriented eczema measurement. What is about the adverse events in this registry? The incidence of conjunctivitis, 29.6, incidence of other ocular manifestation, 5.6, but with 0 patients with herpes simplex, 0 patients with eczema herpeticum. Also, this registry demonstrated that only 4% of the patient discontinued or stopped the treatment due to adverse events, and only 3% of patients stopped medication due to ocular adverse events. That's why this real-world registry confirmed the results of phase 3 study of dupilumab. The results, we can say that consistent with the results of phase 3 study, consistent with the result of SULO 1, SULO 2 Crohn's study. And thank you.
Thank you, Professor Ayman, for this comprehensive answer. And my next question will be for Dr. Ayman Al-Harbi. Are there any other registries can you tell us about?
We have ADRES J, which is Atopic Dermatitis Disease Registry in Japanese adult patient with moderate to severe atopic dermatitis. This study, it's over 2 years, and also the benefit and the aim of this study to understand the status current atopic dermatitis treatment in Japan and compare the treatment with each other and the effectiveness of the medications in moderate to severe atopic dermatitis patient. And also they also mention about the side effect and of all medication and the long-term safety over the 2 years in atopic dermatitis patient in Japan. The study collect data from 10 to 20 hospitals in Japan. And also there is another registry which is called Globostad registry. And the Globostad registry is observational study of adult patient receiving Dupixent for atopic dermatitis. The participant in this study is 1,000, and also it's prospective studies, and the duration of this studies is around 60 months. An estimated study completion date it's around April 2026, and the participant should be the age more than 18 years and above. And the study in many countries, including Middle East and United States, and also in Latin America. And the study shows the effective of Dupixent on atopic dermatitis and also the long-term safety of the Dupixent on atopic dermatitis patient in all of those countries.
Okay, thank you, Dr. Ayman. My next question for Dr. Ahmed Ismail about Dutch BioDay registry. We know is very important registry for the dupilumab. Can you tell us about this registry and the outcomes at week 16?
Now we are going to discuss the BioDay 1. This is for the Dutch Society of Dermatology. This study enrolled about 1,200 patients. And now I think we have the result for the patient starting from 2017, 2018. This study enrolled all these patients above 18 years old, and all patients should be eligible for receiving the Dupixent according to the Dutch Society of Dermatology. All patients suffering from moderate to severe atopic dermatitis, all of them received Dupixent. During the study, the application of topical corticosteroid is allowed according to the patient need, according to the clinician evaluation. All patients should be evaluated by the week 4, week 8, week 12, and week 16. And we are using different assessment tools like EASI score, like brightest numerical rating scale. We are using also the BOIM score, and used also the DLQI index. If you are going to see the patient characteristic for this, we can find that many patients which enrolled in the study have a lot of other atopic comorbidities. For example, we can find some patients have allergic rhinitis, some of them have bronchial asthma, some of them have food allergy, and even about 89% from the baseline have conjunctivitis. And this is very important, and this will hire a question. If these conjunctivitis is related to the disease itself, or it will be increased by development by injection of the patient with the Dupixent, to check if these are related to the disease or to considered as a side effect of the Dupixent treatment. Now, if we are going to discuss the result of this study, we can see here in this figure, if we are talking about the mean improvement regarding the EASI score, we can find that 73.1% of patients achieved EASI change by the week 16. In addition to if you are going to see the characteristic of this improvement regarding the score, we can find that 85.7% of the patients achieved EASI 50 by the week 16, and also 61.7% of the patients achieved EASI 75 by the week 16. In addition, that 24 of the patients achieved EASI 90 by the week 16. And I think this is consistent with the result of the randomized controlled trials like Crohn's, like EASI, like the Crohn's study and CAFE study also. Now, if you are going to see another assessment tool, which is the brightest NARS score, if you are going to check another assessment tool, which is brightest NARS score, we can find that there is more than 50%, I mean 53.5% of patients achieved improvement in the NARS score by the week 16, which is very important, because as we know that brightest is a very important burden for atopic patient. In addition to also the BOIM score, we can find that 91.8% of the patient achieved that more than 4 points improvement in the BOIM score from the baseline, and also this is consistent with the result of Crohn's and the CAFE studies. So overall, we can find that 98% of patients treated with Dupixent achieved clinical relevant improvement in at least one key of atopic dermatitis domain. The most reported side effect is development of conjunctivitis during treatment and even eye irritation. We can find that 34 patients developed eye irritation and 47 patients developed conjunctivitis, and we have to differentiate if it is related to the disease comorbidity or after starting the Dupixent treatment. Out of these 47 patients with conjunctivitis, we can find that 20 patients have just mild conjunctivitis, and 27 patients had moderate to severe conjunctivitis and required the treatment by ophthalmologist.
Thank you, Dr. Ahmed. Just I want to clarify one point. You raised a very important point that the conjunctivitis, either from the disease itself or from the side effect of the Dupixent, away from studies, all these things, statistics, I want to know your feeling from your practice. What do you think?
From my point of view, from my clinical practice, I don't have much case on conjunctivitis. Maybe I have 1 or 2 cases within 40 or 45 patients treated with Dupixent. So I don't feel that the problem of conjunctivitis as much as mentioned in the different clinical trials. I don't know, maybe related to some racial variation, we have something protective here, I don't know.
Thank you, Dr. Ahmed, for your comprehensive answer. And my next question will be a continuation for the previous question for Dr. Ayman Al-Harbi. The same thing for Dutch Bioday registry. We need to know the results for efficacy and safety beyond week 16.
Yes, on that study, they found that the patient with the severe atopic dermatitis sign, it's improved actually in week 52 with time. So the effectiveness, it's still the same, and also it's increased with through the durations. So the study also shows that the pruritus is reduction by 60% with patient started on the treatment of Dupilumab during week 52 by 60.5%. So also in comparing of the Dupilumab to the methotrexate and the cyclosporine patient, they found that the Dupilumab, it's have the superior effectiveness with the duration on the methotrexate and the cyclosporine. And also they found that the people with methotrexate and the cyclosporine, usually there is a lot of failures secondary to the side effect of those medication, and also sometimes failure of the treatment. While the patient on the Dupilumab, they still the same effectiveness and more during week 52 by using a Dupilumab. So I think Dupilumab still have long-term safety and effectiveness with long durations on patients with the severe atopic dermatitis.
The maximum efficacy of Dupilumab achieved between week 24 and week 28. It is very clear. And the involvement of the patient continue until 52 weeks, because the first impression and the first data from SOLO 1, SOLO 2 trial indicate that the maximum efficacy achieved at week 16. But real-world registries and the studies demonstrated that maximum efficacy achieved between week 24 and week 28, and some patients continue to improve until week 52. That's why when we define failure to Dupilumab, the failure, we should not stop the medication at week 16, no. We should wait until week 24 or week 28 even. If the patient failed to achieve AZ 75 or AZ 50 at week 16, we should wait until week 24 or 28 to assess their efficacy. And thank you.
They found it's very safe. Only there is a minor side effect, including conjunctivitis, injection site reactions, and herpes simplex sometimes. But all of this side effect is treatable and not lead to discontinuation of the medication during the treatment. So if in some countries they found that conjunctivitis, for example, it's more common related to the disease more than related to the medication. And also they found that patients with atopic dermatitis started on the Dupilumab, they have good benefit and improve sometimes the conjunctivitis. So the conjunctivitis, it can be a side effect of the treatment, and sometimes is related to the disease itself.
Before the last topic, I would like to highlight about the real-world evidence COVID-19. And my next question will be for Professor Ayman Al-Jindi. What do you know about real-world safety of Dupilumab in atopic dermatitis patient during COVID-19, Prof?
My opinion, Dupilumab is highly effective during the era of COVID-19. Dupilumab is not associated with increased risk of COVID-19 or increased susceptibility of COVID-19. And on the other hand, Dupilumab treat bronchial asthma, improve skin barrier, decrease the risk of bacterial infection and viral infection. That's why Dupilumab even may improve the risk of severe COVID-19. That's why discontinuation of dupilumab may cause exacerbation of atopic dermatitis, exacerbation of bronchial asthma, which may be associated with increased risk of COVID-19 or poor outcome of COVID-19. And recently, there is a very interesting study, included 200 patients with atopic dermatitis treated with dupilumab during the era of COVID-19. The surprise here, none of those patients developed COVID-19. And as we see, none of patients developed COVID-19. 0 patient demonstrated worsening of manifestation of COVID-19. 0 patient require hospitalization, and about 96.5% of the patients continue on dupilumab, which confirmed the safety of dupilumab during the year of COVID-19. And my opinion, even if the patient developed the COVID-19 infection, he should continue on dupilumab. It's very safe even for the patient with positive swab for COVID-19 or for patient with signs and symptoms of COVID-19. On the other hand, even it may improve the outcome of COVID-19. This slide, we have very interesting registry, SECURE-ED registry. SECURE-ED registry include 145 patients with moderate to severe atopic dermatitis treated with immunomodulators. About 93% of these patients treated with dupilumab, and those patients developed COVID-19. This registry evaluated impact of COVID-19 on patients with atopic dermatitis treated with immunomodulators, and also measure the impact of immune modulator on the outcome of COVID-19. And on the right side, as this figure showed, higher prevalence or higher incidence of patients treated with dupilumab showed complete resolution of symptoms. Also, dupilumab treated patients showed shorter duration of symptoms, while on the other hand, patients treated with immunosuppressive treatment showed 3 times increased risk of hospitalization or visits to hospitals. That's why, as we see, dupilumab improved the outcome of COVID-19 in patients with atopic dermatitis, and also indirectly, dupilumab reduced nasal discharge, improve rhinitis, improve cough. That's why dupilumab even may improve the transition of COVID-19 or transmission of COVID-19.
Okay, great. What I get from you that dupilumab may add a protective factor and maybe a treating factor for the COVID.
From my opinion, yes.
Okay, then do you suggest that can we add or think about dupilumab in a strategy of treating COVID-19, or not to that extent?
In the protocol.
In the protocol?
My opinion, if the patient
without atopy, I mean.
Without atopy, I don't recommend.
Okay, fine. Thank you. My next question would be for Dr. Ayman Al-Harbi. To summarize the last topic, please.
Yes, in summary, we will see that the dupilumab is the first approved treatment for atopic dermatitis. This is regarding to the 3 years open label extension studies and multiple atopic dermatitis registry worldwide, and more than 157,000 atopic dermatitis patients treated globally since launch. In real world clinical practice, patient with severe atopic dermatitis and moderate to severe atopic dermatitis on dupilumab experience that there is sustained and clinically significant improvement of atopic dermatitis signs, symptoms, and the quality of life improved. And also there is a significant long drug survival rate compared to the patient treated with the other. So I think in summary, the Dupilumab is still the most effective and the most safe medication for severe atopic dermatitis patient, and it will be decrease the burden of direct or indirect.
Okay, great. My next question for all colleagues. How satisfied are you with the current available atopic dermatitis management options? We'll start with Professor Ayman.
I am highly satisfied now. I am highly satisfied with the current available medication for atopic dermatitis. Why? Now we have Dupilumab. Also we have oral JAK inhibitors like baricitinib. As we know, Dupilumab is highly effective with high safety profile. Also patients who fail to respond to Dupilumab or with intolerance to Dupilumab, we have other options, oral JAK inhibitor. That's why the new medication really changes the game of atopic dermatitis and it changes the landscape of management of atopic dermatitis. That's why I am highly satisfied with this medication.
Now, for me, I can classify the stages of treatment of atopic eczema into two eras. First era is the era only of conventional systemic treatment, and second era is the era of biologics. Before, we don't have any specific treatment. We are using cyclosporin, we are using off-labelly methotrexate, azathioprine, but now we are in a new era, the era of biologics. Till now, we are satisfied with the result of Dupixent, and inshallah, we'll keep on this. We'll add a lot of patients to have a benefit from treatment with such a useful medication.
You want to add anything?
Yes, I agree with Prof. Ayman and Dr. Ahmed about that we have nowadays a lot of guns to treat patients with severe atopic dermatitis, and that will help us and help our patient and improve quality of life in all of the patients with the severe atopic dermatitis. So we hope in the future also there is a research about more biological treated for those patients with the severe atopic dermatitis.
Okay, thank you. And my question to you, I cannot say anything more than what you said. Actually, yes, we have a great gun against this chronic difficult condition, especially in moderate to severe atopic dermatitis. And as my colleague Dr. Ahmed said, we have a different era with this newcomers and new medications which enable us to control and change the life and the style of life of our patients. Yeah, it will be very great. Okay, and my next question to Dr. Ayman Al-Harbi. What are your suggestions to implement similar registry in Saudi Arabia, in our country?
I think we need multi-centers, a multi-research center approach for data collection, and we need this data collection help us and help our patient to compare treatment, different treatment of on the severe atopic dermatitis patient, and help us to find the effectiveness of those medication and also the safety of the medication and also the side effect. So this is what we need nowadays, multi-research centers in our countries.
Fine, good. Now we will move to the last topic, the meta-analysis and systemic reviews. Actually, my coming question to Dr. Ahmed Ismail. What is the available real-world evidence on the Dupilumab, Dr. Ahmed?
We have here an excellent one published in Journal of American Academy of Dermatology, talking about the real world evidence of Dupixent efficacy and other risk adverse events. This is a systemic review and meta-analysis. In the systemic review and the meta-analysis, they examined the evidence of the efficacy and safety profile of Dupixent in treatment of atopic dermatitis. These include about 24 publications were included, covering 22 unique studies. With total number of patients was 3,300 patients. 20 of these studies examined the efficacy of this medication in adult population. One of them examined the efficacy and safety in adult and children, and the last one, examined this in the children only. These studies done in Asia, in USA, and in Europe, in the Middle East, one in the Middle East, and also in North America, they have 7 publications for this. All this meta-analysis, the measurement or the primary endpoint was the mean percentage of changes in the EASI score, in addition to the proportion of patients treated with Dupixent achieved 50%, 75%, and 90% improvement in the EASI score. So they showed this. Regarding the efficacy data of dupilumab from this study, they showed an agreed improvement and improvement regarding the EASI score from the baseline one, which was comparable to the one published in the randomized controlled trials for atopic dermatitis, and the weighted mean reduction in EASI score was about 70% after 16 weeks of the treatment with the Dupixent. And if we can see here on this graph, the percentage of people developed improvement, EASI 50 improvement in the atopic dermatitis, we can find that 85% of patients achieved EASI 50 within 16 weeks, and about 60% of patients achieved EASI 75 within 16 weeks, and about 26 or 27% of patients achieved EASI 90 within 16 weeks of treatment. Regarding the improvement also in another measurement tool, which is the IGA, we can find by 16 weeks about 61% of patients achieved IGA 0 or 1 at a different assessment tool for severity of atopic dermatitis, which is comparable to the result of randomized controlled trial.
Thank you, Dr. Ahmed. Dr. Ayman Al-Harbi, how do you rate the safety data of dupilumab?
So as we mentioned before, that the dupilumab is very safe and very effective medication. Regarding to the ball proportion criteria, they found that the ocular side effect it's around 45%, but the conjunctivitis only represent the keratitis it represents 6.2, which is very rare, and also that they found that the side effect of the dupilumab like herpes simplex and conjunctivitis, and also injection site reaction, all of these is treatable and not lead to discontinue of the medication. So overall, the long-term safety of the dupilumab is very safe and very effective, and also the duration, the effectiveness increase more and more. So we hope in the future we found more gun like the dupilumab in treat patients with with severe atopic dermatitis.
Totally agree with you. Yeah, we encourage such new comers and new medications for this condition and for all the dermatological diseases which we are fighting against. But let me clarify one point you mentioned that maybe I didn't get it well. And allergic conjunctivitis, you mentioned 40 plus? With the
no, allergic conjunctivitis regarding to the dupilumab, it's from 10 to 20%. Actually, which is a minor side effect, and it's treatable. I have patients actually from the clinical practice. They get conjunctivitis, come to my clinic, and he said, "Doctor, please, I'd like to continue the dupilumab because he found that the other symptom is really improved."
Okay, thank you. Based on your clinical practice, we need a description for the patient profiles. Typically, we prescribe the dupilumab for. This is question for Professor Ayman and Dr. Ahmed. Prof. Ayman.
The profile of the patient, patients which are eligible for dupilumab, patient number 1 with moderate to severe atopic dermatitis who fail to respond to topical medication or phototherapy. Also, sometimes can be prescribed for a patient with mild atopic dermatitis if mild atopic dermatitis affects some visible area like face, or if atopic dermatitis associated with poor quality of the life of the patient due to stigmatization. Also, those patients are eligible for dupilumab.
Okay. But what about, you mentioned the face. The face. What's your own experience about the face?
You mean efficacy?
Yeah, the efficacy for the face.
I think dupilumab, it is effective, but not highly effective, because many publications demonstrated that face and neck lesions showed poor response to dupilumab. Even some patients may develop neck and head and neck erythema after dupilumab, but this is different issue and maybe due to so many cases, but this is treatable with, for me, with what we have. If the patient with facial lesion, or if the patient develop erythematous rash on face and neck, can be treated with topical antifungal, systemic antifungal with topical steroid. Within 2 weeks, they will be good improvement.
For me, the patient profile eligible for receiving Dupixent is patient with moderate to severe atopic dermatitis, which is eligible for other systemic treatment. For me, it will be the first choice to give him the biological treatment instead of giving him the old conventional therapy. So any patient who is moderate to severe eligible for systemic treatment is eligible for Dupixent from my point of view.
Okay, agree. Thank you. Okay. Based on your clinical practice, how satisfied are you with the clinical outcomes regarding efficacy, safety you see with dupilumab, Dr. Ayman Al-Harbi?
Actually, as I mentioned before, most of my patients is happy about the treatment and want to continue the medication because long-term safety. Even nowadays with Corona, Prof. Ayman mentioned, it's very safe, very effective medication. It's not decrease the immunity. So it will be help our patient to improve the sign and the symptom. We know that from the beginning, my patient, I see that the itching, it's improved from the first dose actually of the dupilumab. The patient coming to my clinic, he said, my life changed. I have a lot of practice nowadays. He thanks a lot. So everything is okay now with the dupilumab, alhamdulillah.
Alhamdulillah, okay. Just last thing, I want to share it with you all. I need your experience regarding this because a lot of time we are facing this in cases which we need to stop the medications for a while, or some people call it drug holiday. It is actually not our choice, but sometimes it's due to supply problems, due to financial issues, due to administrative obstacles. So what is your experience and what is your suggestion? When we can stop the medications, the dupilumab, for how long? Start with Prof. Ayman.
For me, I always recommend continuous treatment with all biologics.
Yeah, we agree about this, but we said about...
Regarding if situation require discontinuation of medication like pregnancy, for example, I think that the patient maintain his efficacy for about 2 months. But the good news here, with dupilumab, stop and restart is not associated with loss of efficacy. The patient regain the same efficacy, and this is due to the low immunogenicity. That's why for some patients, we can give drug holiday up to 2 months, and when we start the medication again, I think nearly all patients regained their previous response.
I'm not going to stop the medication unless we have some circumstances.
Yeah, what I mean, that some people, for example, they are buying the medication. They are not covered by companies or by the governmental.
As Prof.
So
Ayman said,
if the patient tell you, doctor, my financial situation cannot tolerate this, so I want you to give me a plan or something which I can reduce the expenses.
This is from my point of view only. He can stop, as Dr. Ayman said, up to 2 months, and then we can go back again to restart if you'd like to take a drug holiday.
Yes.
And this, I think he will start to gain regain again the profit from the medicine again.
Okay, good. Dr. Ayman, the same question, and I need your experience regarding this.
I agree with Prof. Ayman and Dr. Ahmed, but the good point here that I have patients stopped the medication for insurance company. Then after that, after 1 year, he returned back on the Diplomab. The effectiveness is the same, and this is good, and he's happy now, and alhamdulillah, everything is okay with him on the Diplomab. So the effectiveness of the treatment, also with those patients stop the medication, if he retain back on the medication, is still the same, almost the same, and that's good for 2 patients on my practice.
Okay, thank you. Last thing, just I want to clarify one point, any of you. Is there any disease-modifying effect for the Diplomab?
I don't think so. Why? Because disease-modifying effect means long-term efficacy after discontinuation of the test.
Yes.
And if we go back to trial, solo continue trial compare between 3 treatment interval, every 2 weeks, every 4 weeks, every 8 weeks. After high response, after when the patient achieved high resolution of the lesion, you compare between 3 interval, 2 weeks, 4 weeks, 8 weeks. This study demonstrated that the highest efficacy achieved with 2 weeks interval, then 4 weeks and 8 weeks, which means is that the long-term efficacy after discontinuation, or the patients can't maintain the response for a long time, maybe, as I said before, at most 2 months. That's why we can't consider this a disease-modifying effect.
You want to add anything, Dr. Ayman? Okay. Dr. Ahmed? Okay. Okay, now we reach to the end of the TRAD session. And by this, I would like to thank all my colleagues and Sanofi company for all the members of this company who are supporting us and give us this opportunity to meet you and to give you some about the colleagues' experience and their updated knowledge. Thank you all, and I hope to see you again in next activities, inshallah.